We're going to be discussing anesthesia for COVID-19 patients at Helen Joseph and Rahima Musa Mother and Child Hospitals. The current outbreak of novel coronavirus was first reported as a cluster of pneumonia cases on December 31st, 2019 in Wuhan, China. The World Health Organization declared COVID-19 as a public health emergency of international concern on January the 30th, 2020, and on 11th March 2020, the World Health Organization characterized the spread of coronavirus as a pandemic. Severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, is a non-segmented positive sense RNA virus and is part of the family of coronaviruses. It targets cells through angiotensin-converting enzyme 2 receptors, which are expressed by epithelial cells of the lung, intestine, kidney, and blood vessels. In addition, ACE2 receptors play a role in the development of hypertension and diabetes and are present in greater numbers in people with cardiovascular disease. The disease that SARS-CoV-2 causes is called COVID-19. CO for corona, VI for virus, and the D is for disease. So far, the mortality rate of COVID-19 is roughly 3.4% worldwide, according to the World Health Organization. However, this rate will vary between countries and across age groups. The World Health Organization estimates the death rate is far higher than that of the seasonal flu, which kills about 0.1% of those infected. So how contagious is COVID-19? A crucial metric for understanding an epidemic is measuring how quickly it spreads. One way to do that is to look at how many people on average a person with the virus infects. That's known as the R0. COVID-19 has an R0 of roughly 2 to 2.5, meaning that each new person spreads the disease to about 2.2 people on average. That makes COVID-19 more contagious than the seasonal flu, which has an R0 of 1.3, but less contagious than SARS, which has an R0 of between 2 and 4. A R0 of more than 1 means the disease is continuing to spread among people exponentially. COVID-19's global spread and relatively high death rate are ringing alarm bells. It is spread by respiratory droplets. People get exposed by physical contact or by touching surfaces contaminated with respiratory droplets. What are the symptoms of COVID-19? In most cases, COVID-19 causes mild symptoms, including a sore throat, non-productive cough, fatigue, and fever. The most common presenting symptom has been fever. An estimated 15% develop severe disease that can lead to pneumonia, with hypoxia, dyspnea, and tachypnea, while 5% become critically ill with respiratory failure, septic shock, and/or multi-organ dysfunction. The proportion of asymptomatic carriers is currently unknown. Gastrointestinal symptoms such as nausea, vomiting, and diarrhea appear to be uncommon. The mean incubation period for COVID-19 is estimated to be 4 to 5 days, with an interquartile range of 2 to 7 days. There's a direct correlation between mortality and age. Based on the retrospective data we have so far, if you're between 60 to 69, the mortality rate is 3.6%. If you are between 70 to 79, it's 8%. And if you're 80 or above, it is 15%. A February 2020 study from the Chinese Center for Disease Control and Prevention showed that the virus most seriously affects older people with pre-existing health problems. Preliminary information is being provided by studies looking at the disease pathway in Italy. They recommend avoiding ibuprofen and other non-steroidal anti-inflammatory drugs if possible. A recent article that was published in The Lancet also makes the following observations. 1. The expression of ACE2 receptors is substantially increased in patients with type 1 or type 2 diabetes and hypertension who are treated with ACE inhibitors and angiotensin receptor blockers. ACE receptors can also be increased by ibuprofen. Consequently, the increased expression of ACE receptors would facilitate infection with COVID-19. They therefore hypothesize that diabetes and hypertension treated with ACE2 stimulating drugs may increase the risk of developing severe and fatal COVID-19. Having said this though, the American College of Cardiology, the American Heart Association, and the Heart Failure Society of America released a statement on the 17th of March stating that currently there are no experimental or clinical data demonstrating beneficial or adverse outcomes with background use of ACE inhibitors, angiotensin receptor blockers, or other renin-angiotensin-aldosterone antagonists in COVID-19 or among COVID-19 patients with a history of cardiovascular disease treated with such agents. They recommend continuation of renin-angiotensin-aldosterone antagonists for those patients who are currently prescribed such agents for indications for which these agents are known to be beneficial. In the event that patients with cardiovascular disease are diagnosed with COVID-19, individualized treatment decisions should be made according to each patient's hemodynamic status and clinical presentation. Therefore, be advised not to add or remove any renin-angiotensin-aldosterone system-related treatments beyond actions based on standard clinical practice. So as far as preoperative assessment is concerned, elective surgery should currently not be performed. All patients coming to hospital should be screened according to these National Institute for Communicable Disease Protocol to identify patients at risk of having SARS-CoV-2. Okay, just note that these guidelines were in fact amended on the 25th of March.
Before I discuss the personal protective equipment, I need to mention that in order to avoid depleting PPE supplies during the pandemic, routine personal protection like regular hand washing and non-sterile glove used from non-COVID-19 patients should not be supplemented by additional PPE. For routine care of confirmed or suspected COVID-19 patients, contact and droplet precautions should be used at all times. SASA recommendations for routine care of COVID-19 are as follows. We must use disposal gloves, disposal apron, face mask, usually disposable surgical masks should be adequate, eye protection, goggles or face shield may be considered optional. Normal glasses are not considered eye protection. Importantly, hands must be washed or have alcohol hand scrub decontamination before and after removing gloves, as well as after removal of other protection equipment like apron, mask, etc. This level of PPE is appropriate for clinical examination, preoperative assessment, and transfer of patients between care areas and postoperative visits. Enhance personal protective equipment for intubation and other high-risk aerosol generating procedures. They recommend that we should use a fit-tested N95 or FFP2 respirator or alternative of equivalent standard, eye protection and or full face shield, long-sleeved, preferably impermeable gown, disposable head covering or theater cap, and double gloves, preferably long gloves over the gown sleeves. The following are examples of aerosol generating procedures during intubation, extubation, bronchoscopy, airway suctioning, high frequency oscillatory or jet ventilation, tracheostomy, chest physiotherapy, high flow nasal oxygen therapy, and nebulizer treatment. Let's now discuss the difference between surgical mask and respirators. A surgical mask protects against infectious agents transmitted by droplets from the person wearing the mask. It therefore protects the people and environment surrounding the person wearing the mask. The N95, N99, FFP2, and FFP3 are commonly referred to as masks, but these are in fact disposable respirators. Respirators are designed to filter inspired air and protect rather than prevent droplet contamination from the user. Therefore, in no circumstances should respirators be provided to patients, as it will most likely exacerbate dyspnea. Respirators can be divided into disposable and reusable. The disposable respirators are as following. N95 and N99 respirators provide protection against solid and liquid aerosol particulates that do not contain oil. The difference between N95 and N99 is simply the filter's efficiency level. N95 filters, they protect 95% of particulates, and N99 filters, they give an efficiency of 99% of particulates in the air. These respirators are classified accordingly to the United States standards. On the other hand, FFP2 and FFP3 are respirators classified accordingly to the European standards and are essentially equivalent to the N95 and N99 respirators. The difference between, however, is that the Europeans don't only test the filtration percentage, like the Americans, but also the percentage of maximum leakage to the inside. So FFP2 respirators have a 94% filtration percentage and a maximum of 8% leakage to the inside. On the other hand, FFP3 respirators have a 99% filtration and a maximum of 2% leakage to the inside. Reusable respirators. Reusable respirators can be full face or half face protectors. They also come in full face and extended protection, like this mask in the picture, which will protect your shoulders and upper body as well. The extended part can in fact be a complete suit or offering a full body protection. These need to be disinfected immediately by the person who has just used it. Importantly, Helen Joseph Hospital and Rahima Musa Mother and Child Hospital has invested in these reusable devices, and we will soon draw up a protocol on exactly how to disinfect them. As we discuss in reusable equipment, I just wanted to mention that reusable eye protection shields are also available. These, once again, also need to be disinfected immediately. How to feed a respirator. Respirators must be correctly fitted to be effective. This is done by conducting a fit test. Health workers should don the respirator, making sure it has a tight seal. Pinch the respirator over the bridge of your nose. Breathe out deeply against the resistance of the respirator and check for any air leaking from the sides. Then breathe in deeply and again make sure there is no air entering the mask from the side. Facial hair like beards prevent a good seal and should be shaved off. When removing doffing the respirator, only touch the straps and not the respirator itself. In the absence of an adequately fitted respirator, power air purifying respirator PAPR devices can be used. Once again, we will chat a bit later about them. So now we have discussed the personal protective equipment available. In what order do we need to put it on before entering theatre? This we will call it as donning, and the Anaesthetic Department of Helen Joseph Hospital and Rahima Musa Mother and Child Hospital have decided that we will put on our personal protective equipment in this order. We have used both the Canadian and the CDC guidelines. To avoid self-contamination, we have decided to remove or doff our PPE in this order. Both donning and doffing can be viewed in the videos we have created.
Okay, so anesthetic management for COVID-19 patients. Just some general considerations. Your personal protection is the priority. Personal protective equipment should be available for all providers to ensure droplet contact isolation precautions can be achieved. Careful attention is required to avoid self-contamination. Patients with confirmed or suspected SARS-CoV-2 should not be brought to receiving areas. They should be managed in the designated operating theatre with signs posted on the doors to minimize staff exposure. They should be recovered in the operating theatre or transferred to ICU. It's important to remember that when you're transferring an ICU patient, you need to put a high quality HME filter between the ET tube and reservoir bag during transfers to avoid contaminating the atmosphere. You need to plan ahead. You need to allow for time for all staff to apply PPE and barrier precautions. Okay, we're going to go over the Helen Joseph and Rahima Musa Mother and Child protocols. So as soon as a case has been booked, all staff that's involved need to be informed. The staff number needs to be limited to the minimum required. For anesthesia, we recommend 2 anaesthetists in theatre and 1 anaesthetic runner outside theatre. A designated theatre needs to be prepared, and at Helen Joseph Hospital we decided that that theatre will be Theatre 4, and at Rahima Musa Mother and Child Hospital it will be Theatre E. Only necessary equipment needs to be in theatre, and both of these theatres have been set up appropriately. So the other extremely important thing is to not take any personal items with you into theatre. Okay, so airway trolleys will be prepared and ready, and it will contain your video laryngoscope with disposable blades or reusable blades, an additional laryngoscope and blades that's disposable, face masks of different sizes, ET tubes of different sizes, Waddell Airways, introducers, supraglottic devices, and trachea tape. You need to take whatever you think will be needed for the airway management. The rest can be left outside theatre and can quickly be requested for from the runner. All drugs needed must be prepared and taken into theatre drawn up in syringes. The anaesthetic trolley with all other drugs will be left just outside theatre, accessible to the runner. The drip needs to be prepared, and only the fluid that is anticipated to be needed must be taken into theatre. Closed suction catheters should be connected at the time of intubation to avoid unnecessary disconnections for suction. You should use wall suction instead of electrical suction as far as possible. Once again, You can watch the videos we've created to see the intubation and extubation plans for Helen Joseph and Rahima Musa Mother and Child Hospitals. As far as regional anesthesia is concerned, the exact same considerations regarding preparing theatre, drugs, staff as for your general anesthetic. The patient needs to be taken directly to theatre. If the patient is wearing a surgical mask, the minimal personal protective equipment that must be donned is an apron, eye protection, a surgical mask, and double gloves. The first pair will be removed after you've positioned the patient post-spinal. You should be scrubbing for the spinal, and we recommend that you wear a gown over the apron and then your double gloves. If the patient is wearing an oxygen mask or will require supplemental oxygen intraoperatively, and because of that is at risk of aerosolizing, you should wear an N95 respirator. Okay, at all times, the patient needs to wear the surgical mask. Okay, and as far as possible, try to avoid giving the patient supplemental oxygen via venturi mask. According to guidelines endorsed by SASA, there is no evidence that an epidural spinal is contraindicated in the presence of coronavirus. All the usual contraindications to neuraxial blocks apply as normal. You need to check platelets in all patients after approximately 1/3 of patients in a case series from Wuhan developed thrombocytopenia with a platelet count of less than 150. Donning PPE is mandatory no matter what the anesthetic use. You should try to avoid general anesthesia unless absolutely necessary for standard indications, but you need to consider plans for management of failed regional techniques. In case of a difficult intubation, Plan B is to use a second generation supraglottic airway, and Plan C will be to use front of neck access scalpel bougie tube. Okay. This guide is based on early and preliminary information we have available. We need to remember that this is a rapidly evolving space with new information daily.
This picture is a picture of someone in a powered air purifying respirator. This can be used as an enhanced PPE for confirmed or highly suspected COVID-19 case. We at Helen Joseph Hospital and Rahima Musa Mother and Child Hospital will be getting 3 of these. It is equivalent to FFP3 respirators. The advantages though include that is more protective than a half face or even a full face respirator, as it covers your entire face, neck and shoulders. The PAPR is usually more comfortable because air is forced into the mask by the blower, producing a cooling effect. The PAPR is durable and breathing resistance is lower. The components of a powered air purifying respirator include purifying air generator. This is run by battery. This will be placed on the waist using a belt. This purifying air generator will be connected to the face shield using a breathing hose. The filtration of air occurs within these filter boxes, which will be incorporated in the purifying air generator. All of these pieces, except of the filter, they can be immersed in disinfectant and get properly disinfected. In our setting at Helen Joseph and Rahima Musa Mother and Child Hospital, it is important to note that the power purifying air generator is compatible with this full face respirator also. What are the recommendations for practitioners exposed to COVID-19? If you have occupational exposure with appropriate PPE, you can continue to work with monitoring for symptoms for 14 days. If you become symptomatic, then you need to self-isolate. If you have occupational exposure without PPE, then you need to self-isolate immediately and conduct SASA regarding testing and monitoring of symptoms. The fight to combat COVID-19 is going to be a marathon effort by all the healthcare providers and will require ongoing resilience and determination. It is normal to feel sad, stressed, or overwhelmed during a crisis. Talk to people you trust or talk to a counselor. Maintain a healthy lifestyle, proper diet, sleep, exercise, and contact with friends and family, ideally without face-to-face contact. We are in this all together. Talk with us. We will help in any way possible. I would like to leave us with the wise words of our President. I call on you, one and all, to play your part, to be courageous, to be patient, and above all, to show compassion. Let us never weary and never despair, for we are a nation at one and we will surely prevail.